Good morning, everyone. And on behalf of the Massachusetts Medical Society, welcome to part 2 of the 9th Annual Care Forum. I would like to thank MACRI leadership and the organization's co-chairs, Drs. Douglas Salvador and Patricia Folcarelli, for providing me the opportunity to speak with you this morning. I don't need to tell you that the last 2 years have been like none other in healthcare as we continue to live in a 2+ year of a clinical trial. We're coming out of, currently the 6th wave of COVID. The pandemic is still with us, but we are in a much better place than we were in 2020. We have a better understanding of the disease itself. We have access to therapeutics, and Massachusetts enjoys a high vaccination rate. Yet physicians face ongoing challenges due to workforce shortages and delayed patient care. Misinformation and disinformation about COVID have caused an erosion in trust in science and healthcare. COVID has also exacerbated mental health issues and exposed persistent healthcare disparities and inequities amongst the most vulnerable populations. We must utilize the lessons learned from COVID to improve public health and care delivery. We are all affected both on a professional and, for many of us, on a personal level by COVID. When adverse outcomes occur, it is not only the patient that suffers, but often the caregiver aches as well. This pain is magnified by the fact that too often we aren't able to be as compassionate or transparent as our heart and soul directs. This further damages the trust and relationship between patient and physician. At its core, what MACRI is working toward is right. Physicians and all those in healthcare seek to provide the highest quality and safest care possible. And offering compassion and transparency in the wake of a medical error can help the patient and their loved ones in the healing process and provide root cause analysis critical to improvements in patient safety. Care is on track to expand. As MACRI's care approach continues to gain traction, we continue to work to expand to additional states and even nationally. The Massachusetts Medical Society's advocacy team is committed to partnering to make sure that laws and regulations most supportive of the mission of MACRI come to being. The MMS is committed to healthcare safety. The MMS is an active executive committee member of the Massachusetts Healthcare Safety and Quality Consortium. The consortium, with its more than 36 member organizations, is leading a collaborative effort to improve healthcare safety in Massachusetts. In 2020, the consortium developed a roadmap to healthcare safety, a statewide strategic plan that sets forth a vision and goals to propel investment, action, and transformative change on safety across the Commonwealth's healthcare continuum. The roadmap to safety is structured around 4 foundational pillars, essentially not only to healthcare safety, but to any well-functioning system. Leadership and governance, under the leadership of Drs. Bomba and Spivak. Continuous organizational learning and improvement, under the leadership of Drs. Bomba and Argi. Supporting patients, families, clinicians, and staff, under the leadership of Drs. Bomba and Metz. And measurement and transparency, under the leaderships of Dr. Bomba and Mellon. The Betsy Lehman Center has convened multi-stakeholder task forces aimed at addressing each of the key areas identified by the roadmap. An action plan is being reviewed by the consortium on June 7th, specifically on the implementation of the roadmap. The MMS understands that patient safety is an integral part of the action plan. The MMS will be monitoring the action plan and the continued efforts. The initiative is supported by state agencies, professional associations, industry associations, and nonprofit safety organizations that are committed to improving safety across Massachusetts. As a founding member, the MMS is a fierce supporter of MACRI's mission and recognizes our important role in patient safety. I am pleased to be a part of today's outstanding program, and thank you for letting me make these opening statements, and enjoy the program.
Thank you very much, Dr. Calianos, and welcome everyone to our 9th annual part 2 of the Communication Apology and Resolution Forum. Today we have an excellent program for you. We're gonna put up the slides for a second. There we go. So before we get started, just some administrative pieces. These are the objectives for the session today. Describe the reasons why the care approach works better than deny and defend for patients, providers, and the healthcare system, and describe the key elements that are important to include in a successful resolution conversation. Next slide. And this is just the disclosure statement. There are no disclosures or any financial relationships with ineligible companies. Next slide, please. This session is eligible for CME and nursing credit if you are watching it live. If you're watching the recorded version, we don't provide asynchronous credit. But to claim your credit for being here today, after this session, within about a 2-week time span, you will receive a link with an evaluation for the entire day today. Once you fill that out, you will be able to receive a link to a certificate. That will be your CME certificate that says you've completed it. If you are a nurse and you want that credit, just email that certificate to me afterwards and I will transfer that into nursing credit for you. Next slide, please. So we're very happy to have you all here today. We have a wonderful morning session for you. Today, we're going to do an introduction to care and recent developments. We actually have a lot of folks from all around the country on this call. So we just want to make sure we're all starting out talking about the same thing. And we want to update you on what has been happening in the care realm for the last year or so. We have some simulation and discussion sessions around first one around a resolution conversation and the second one around how to talk with an involved provider around a care case. And we'll have a testimonial from a family member and a Macrame board member, and then have some concluding remarks. Next slide, please. So to start us off, we want to talk a little bit about some news that Macrame has and that is happening in the care world today. Macrame has become part of the Betsy Lehman Center. And if you're on our email list, you probably know this already. But we are really thrilled to be part of the Betsy Lehman Center now. We think that this will really help us to be able to better support the spread of care in Massachusetts. It gives us a really great support of an organization that already is very well known and respected in the patient safety realm in the state. So we're really thrilled about that. So you'll see today throughout the day that there's this co-branding up here, and so you'll start to see some emails emails coming from the Betsy Lehman Center. My email address will also be coming from the Betsy Lehman Center eventually, and so I just wanted to let you know that you'll be seeing a lot of that. Our Macrame website is still active and you can get your resources on there still. We will be migrating that over to the Betsy Lehman Center website eventually, but all those resources will still remain open and free and available to you. We also, as a group, have been doing our resource creation as we typically do. I wanted to talk a little bit about the process of how we do that. When we are implementing at different sites, sometimes issues come up and they say, what do you do when you have to talk to a provider about that? Or do you have any suggested language? And so when we meet as Macrame, we think about, are there any ways that we can create resources for sites that will help them along in their implementation? And so over the years, we have perfected this process, and that what we do is when we come up with an idea, we have our steering committee draft a document, and then that's shown and edited and re-edited by the entire group of Macrame. And in case you're new to us, that includes physicians, like groups from the Mass Medical Society. It includes attorneys. It includes those that are involved from each of the care sites. It includes those organizations that help represent patients and their perspective, and malpractice insurers. So when we're talking about Macrame, we're really talking about all of those people that are part of the medical liability process meeting together to create these and to prove them. So when you go onto our website and see a resource that's created by Macrame, that's what that means. It means that all of those groups have looked at, revised, and put that resource forward. So this year, we have 2 that we've created. The first is a clinician communication algorithm, and we'll be sort of featuring these in each of the simulations today. But what that first one is really some more language for clinicians when they're going through this process around what do they say to patients at different points in time, what can they expect from the process, really just targeted toward clinicians that are going to be in front of patients for this process. And the second one is recommendations around talking to involved providers about care. And that means that when a provider is involved in an event, they might not know that much about communication and resolution. They may have heard about it before, or they may not, and how to approach that with them and talk about why we use this and how that can be supportive for them too, as well as their patients. And the last piece is our updated attorney list. So we are constantly updating this. This is a resource that we wanted to highlight to make sure that you knew is still available. It is on our website on a page. It says for patients, and then there's a section that says attorney list. This list is generated by Macrame, and what it is a list of attorneys that have been educated in the care process. And we wanted to tell you a little bit about how attorneys get on this list so that you know how you can best use it. The attorneys on this list are self-selected at first. So it's something that they're interested in and want to do. They have heard about the care process and care about it. Then they apply by putting in their resume and answering a questionnaire that we've developed. They also have to have a conversation with our Mass Bar Association representative. Then all of those materials are gathered by the steering committee and they are allowed to move forward or not. If they are, then they must watch an attorney education session, which is a training that talks about why this is important and the best practices around Macrame. And then when they have finished that training, they sign a statement that says they'll abide by the best practices. And you can see those signed statements on the attorney list themselves. So those are the things that we've been working on for the past year and wanted to highlight for you. Again, all of our resources are free and available that we talk about today and that we use in implementation. So please go and take a look. Next slide, please. So communication, apology, and resolution, the basics. We wanted to just start on the same page today to make sure that when we're talking about a care program that we're all talking about the same thing. And these are the different elements of that program. The first, of course, is communication. This is the biggest piece, and really, truly overall, care is about communication and better communication. In a care program, we proactively communicate with patients and families about adverse events. That means that if we know about something and they don't, we tell them. We connect them with team members who can help them throughout care, and we make sure that we are available for their questions and that we really tell them all that we can about being transparent and honest around what has happened to them. The second piece is apology, and this is something that as the language is evolving around care, you probably will see programs called CRPs, and sometimes that leaves out apology. So we just want to emphasize here that that is a really important piece of this program, that we always offer empathetic apologies. And that is, it's an essential piece of being able to move forward after an adverse event, but also where appropriate, an apology of responsibility is also part of this. We don't emphasize that at the beginning because we want to be able to do an investigation so that we know what really is responsible for causing this adverse event. But that is still a very important part of what happens after these events in a care program. Then, of course, we investigate. So investigating and finding the real true root causes of these events and developing corrective actions to improve patient safety. Improving patient safety is one of the most significant benefits of this program. It's really one of the core reasons why we do this, because we are accountable to these patients and families after something has gone wrong, that we want to be able to prevent that from happening again. And we develop corrective actions that will really prevent that from happening, and that we talk to the patients and families about what those things are so that we're accountable to them. The fourth piece is moving toward healing. And this is a really important piece. And I often get questions from those that we're implementing with, what is really different about this process? Like, is this really the same? Could we do this with an attorney, or do we just have to sort of do the regular process? And what I try to say is that this is the piece that is the most significantly different from what you may have used to do, right? So if there's a lawsuit, you're never going to be able to have a conversation sitting in the same room with patients and providers and quality staff, really understanding what has happened and allowing the patient to express their frustration, and to ask questions and to get answers and to have that healing conversation happen. If you skip that, there really is not going to be a true resolution in the way that we try to achieve through care. And this is the piece that, even if a care case is initiated by a claim, this piece can still happen and is one of the most important pieces to being able to have a conversation to say, this is what we found when we investigated this, and this is how we're going to try to resolve it. And that's the place also where we move the case to compensation if it meets the right criteria, which we'll talk about in a minute. And then, of course, resolve. So we resolve the cases with compensation outside of the court system. And of course, patients can have attorneys in this process and ensure that those improvements are made. So this is what we're talking about when we're saying a care program. We mean that all of these elements are in place every case, every time. Next slide, please. Now, a lot of you on this call, I'm sure, know why we use this, but we just want to emphasize again that this really, truly is the best way to resolve adverse events for patients, for providers, and for the healthcare system. Patients are treated with compassion and honesty. They can get the answers and support that they need, and it's a fairer and more timely process than the court system. For providers, it helps to preserve that patient-provider relationship when possible. It can help to be able to express naturally the empathy that you want to express, and also can get providers the support that they need. And also the true systemic root causes are more likely to be unearthed in a process like this, rather than blaming individuals when often there are systemic causes as well. And then better for the healthcare system. There's less defensive medicine, system improvements are made, which is really important. And it builds trust in the system, which then can increase reporting and morale among those that work in the system. Next slide, please. So how does it work? Essentially, when we use this program, we use this on every case, every time. This is what we like to say. And we're all looking at the same potential care events. And if you are part of MacroMe, we will give you a definition of that criteria. It's also online. But that way, we're all looking at the same events to say, are we doing this program for all of these types of events? What we do in every one of those cases is respond immediately to the patient's clinical needs, communicate proactively, express empathy, investigate, make changes to improve patient safety, and inform the patient of those changes. This happens in all the cases. Then the next piece, when we investigate, we sort of bifurcate these cases to decide what happens after that. And I know that this doesn't add up to 100. I can do math, but that's because most of the time it falls into one of these two buckets, and a little bit of the time it doesn't. And actually today we're going to look at a simulation where it doesn't cleanly fall into one of these buckets. And that's part of why we're using that case today, to show you that it can work even if it's not very clear cut. So the two options are standard of care was not met, and that caused the patient significant harm. This happens about 10% of the time. So this is not where we do most of our work in the care program, but it is a significant piece of it, and it's something that's different. Again, we are proactively going to offer compensation, and this is what we call the care insurer pathway. So in coordination with them, we proactively offer compensation, formally apologize, and have that resolution conversation. A lot of that process is done by the insurer, especially the piece around compensation, but how to get the case to the insurer and coordinate that is a big piece of what we do in the care program and in training for implementation. The other piece, the 85%, is where the standard of care was met when you review it, or there was very low level harm. And in those cases, we explain what happened, we answer the patient's questions, continue to express empathy, and there's an option for a goodwill gesture. So, if we know they're going to have to come back in for appointments, you can pay for their parking tickets or things like that, that you want to acknowledge that there is inconvenience and stress around this, and that this is something that we want to be able to support if we can. The other 5% are things like you'll see today, which is something where the standard of care was not met. There was significant harm, but it wasn't causally related. So there are some circumstances where it is not cleanly fit into one of these buckets, but we still proceed with the program and we make a decision around which way we should go. And in some cases, we will go with the explain and answer, and that's still a resolution. And the other side, we will refer that to the insurer. And so each of these is a type of resolution, but we wanted to show you sort of how that bifurcates and what we're doing most of the time. And as I said, most of the time, care is about communication and really helping folks to understand what has happened and how we're going to prevent that from happening again. Next slide. And I just wanted to review the data. So there is a lot of data that's out there now and that is coming out because there are more and more programs doing this. We had a pilot study for 3 years at the beginning of when we launched this. This was from 2012 to 2015. And our study still is the most rigorous to date because it has a lot of different comparators, which was very helpful. And we were able to do it in different kinds of insurance models. But overall, this is what the data shows. Claims and costs do not increase even when systematically using care. And in many cases, they decrease, which is wonderful. What this tells us is that you can do the right thing systematically, every case, every time, and you will not have any kind of financial disadvantage, and you probably will have an advantage. So what we really try to say about this is you can do the right thing and it works for your bottom line, which is not our #1 concern, but it is a concern that a lot of folks have. And so I think that's a really important piece to emphasize. Also, providers are supportive of the program. Our study showed that over 80% that were participating in this were very enthusiastic about it. Patients are supportive of it. And also patients who do not receive the components of the program can receive long-term negative impacts. So if you could just go to the next slide for a minute, this is something that the Betsy Lehman Center put together. And I always use this in my slides because I really feel like it is so important for us to remember what is happening for patients and families when they are not receiving open communication. So you can see here, without open communication, the orange line. So these are patients who felt they had adverse events and did not get any kind of open communication. And then the blue line is those that did. They did get some elements of a care program at least. And you can see there's such a huge difference, especially in avoiding doctor and avoiding facility, that these patients who are not receiving the communication around adverse events from the facility are really hurting. And it's really creating a problem for them down the line. And it probably is also signifying that there is a problem in terms of your facility's bottom line or their reputation, and that they're avoiding the doctors, avoiding the facilities, and that is going to create repercussions in the future. And so these are some things that we really need to think about when we're saying there are other benefits to care, just, outside of what this individual patient is experiencing and the individual case is creating. So next slide, please. And the last one was just that you need to have a real rigorous program to actually receive the benefits of it. And so this program works very well, but you need to do it in a rigorous way where you're tracking the cases, using the algorithms every case, every time. Although lots of facilities use this on an individual case where it's very clear there was harm or a patient is very angry, it doesn't help to get the benefits for the system if you're not doing it on all of your cases. And so for macrame, this is a really important piece. So those that are in macrame use the algorithms and the tracker to help ensure that the good communication is happening with each case. And then they're reporting data to macrame so that there's collective learning around how many cases are we looking at? How are they shaking out? How many times are we communicating with patients in different kinds of cases? And that's been really helpful as a benchmark to those facilities to be able to see, okay, this is how other folks are doing it. And this is where we should be. So next slide, please. So I will say that we're at a really exciting time for communication, apology, and resolution programs. Nationally, this is really gaining a lot of traction. There are over 200 facilities around the country that have implemented or are implementing this. There are, of course, lots of toolkits. Ours is open source, but also the Candor toolkit, which was developed by ARC, is an open source toolkit to support these programs nationally. And so it's marketed by ARC as well. There's a PACT collaborative, which is a new sort of pilot joint venture with IHI, CAI, which is the national collaborative, kind of like a national macrame, and Ariadne Labs. And they have right now 20 systems in a national CRP learning and implementation collaborative. And so they hope to be able to have multiple ones of those. And so we really are moving in this direction. Next slide, please. I will say when I first started working on this over 10 years ago, in 2012, this was a little known idea, and a lot of people thought that it was a little bit crazy because it was the opposite of what we had been taught for so long, to deny and defend. And now we can really truly see a shift all over the country that this is something that we should be doing. And now the question is, how do we do it? And I think what's wonderful about being in Massachusetts and with all of these other groups that are springing up nationally is that there are tools and resources to help you do this the right way. In Massachusetts right now, we have 10 fully implemented sites with 8 more currently working on implementation that should be wrapped up in the next year or so. So that's very exciting. And as part of the Betsy Lehman Center, Macrame has the tools and resources and experience to help you implement this program, and it's free. And we want to be able to help and spread this because we really do believe that it is a very important program for all of those in the healthcare system. So if you are interested in having one of these programs and you feel like you need help to do this, we are certainly available to do that. And you can email me if you'd like. I think probably everyone has my email address, but if you don't, also you can go on the Macrame website and use the contact link there, and we can get in touch. So next slide, please. So that is our introduction to care. We are going to start with our case simulation content. And as we develop the content for these forums, we get a lot of our content from you. So when you get your evaluation at the end of this, you have some suggestions for future things you'd like to see. These scenarios were pulled directly from that, and also from implementing sites that say, you know, this is something we'd really like to see simulated. We know that it's very helpful to actually see the conversations, because they are difficult conversations that happen rarely. And so it's nice to be able to have some resources to see a true interaction. As always, we try to make our case simulations based on real cases, and this one is based on a real case that did happen. Of course, some names are changed to protect privacy, but this is very close to how it went. This is a case where the standard of care was not met. There was significant harm, and there was no causation. So this is a very tricky case. It's a hard case to have conversations with patients and families about cases like this. And so that is why we picked it. And so you'll see the simulation today, and the providers and the hospital staff that are in this conversation really truly were in the real one as well. And so they can, you know, sort of answer some questions after if you have that. The patients and family members are actors in this situation. Next slide first. So I'm going to give you the case description, and then we'll watch the video of the simulation. And then after that, Pat Folcarelli, who is the Vice President for Patient Safety for CRICO and one of Macrame's co-chairs, will lead a discussion session. So after we're done with the scenario, we are welcoming you to turn on your camera and chat. You can raise your hand and we can sort of do that. Or if you feel more comfortable, you can chat through the box. So this is the case, and then we'll play the video. So. Case description. A 72-year-old male patient comes to the hospital's emergency department with chest pain. He has a history of congestive heart failure and a recent urinary tract infection. He is dropped off by his daughter. He waits in the waiting room for approximately 5 hours. He is short of breath and lethargic. When he is taken to a room, an EKG is completed. Based on the results of that study, an emergent cardiac catheterization is done. So next slide, and then you can start the video.
Good afternoon.
Hello.
Hi, this is Edison Bond with the Office of Patient and Guest Relations. How may I help you?
This is Melanie Silva. I'm calling about my father, Sal McDonald. I'm really upset about the care my father received. He had chest pain and shortness of breath, so I dropped him off. I had to get home to take care of my kids. I called at least 10 times to get updates, and I finally got through after about 5 hours, and they said he had gotten back into a room about 20 minutes ago. 5 hours? After that, he ended up needing a cardiac catheterization. I'm sure he had a heart attack because he was not in the room quickly enough. This is just unacceptable. I know there are a lot of sick people right now, but an older man with chest pain should be at the top of the priority list.
I am so sorry, Miss Silva.
And when I asked to be called back with more information, no one called me. Then I called back and found out he had been admitted and is now in heart failure. I expressed concern about how long it was taking him to get treatment, and they responded by telling me that other people had been waiting 9 hours. That is completely uncalled for.
I am so sorry, Ms. Silva. I am sorry for the lack of communication and the rude response you got when you raised the concern about how long your father was waiting in our emergency room. This is not the way we operate here, and I am really sorry. With regard to your father's care, I understand your concerns, and we will review the care he received in our emergency room. We have a process that when a patient or family member alerts us to a problem, we have our quality department review all of the care to determine if anything went wrong and if there were any improvements we could make. I will certainly have your father's care reviewed.
Okay, well, I would appreciate that, but my father is dying. It's hard for me to get in to see him with the COVID protocols and everything, and I really feel like he wouldn't be in this situation if he didn't have that issue with the emergency room. Plus, it's so hard to get information outside of the hospital. I don't even know who I'm supposed to talk to and who is in charge of my father's care.
Yes, I completely understand that. Why don't I work on making you an authorized care partner for your father and getting you a visitor's pass? And let me see if I can reach his cardiologist and see if he can come up and meet with you. Would that help?
Yes, it would. Thank you.
Okay, great. I will work on that immediately. The visitor's pass should be all set by the end of the day, but I will call you later today and let you know. The investigation into his care will take a little longer, usually a few weeks. So I will keep you apprised of any developments on that.
Okay, great. Thank you. And please call me by the end of the day to let me know about the pass.
I will do that, and I look forward to speaking with you.
Goodbye.
Talk to you later. Good afternoon, Mrs. McDonald and Ms. Silver. Thank you so much for coming in to meet with us today. Again, I'm so sorry for your loss, and we hope that this meeting will be able to answer some of your questions and give you a better understanding about your husband and your father's care. I would like to start with some introductions, and I'll go first. My name is Edison Bond. I'm with the Office of Patient and Guest Relations.
Hi, I'm Doug Salvador. I'm the Medical Director of Quality here at the hospital.
And I'm Dr. Ibarra, the cardiologist. We spent a lot of time together back in March.
I'm Melanie Silva. I'm Sal's daughter.
I'm Sal's wife of 57 years, Mrs. McDonald.
Thanks again for coming in to meet with us. What we hope to do today, as you know, a group of doctors and nurses got together to review the care that your dad and your husband received while here. We want to explain what happened, and we're here to answer all the questions you have as long as it takes. We want to apologize where we've made mistakes, and then we'd like to tell you about things we've done and we've learned from your dad's care to try and make sure that the care is better the next time.
Ms. McDonald, Ms. Silva, I am so sorry for what you experienced here in March and what Sal experienced here in March. Without recounting everything, I think we could say that the last few months of his life were difficult. I'm going to try to give you an overview of what I think happened over the span of time in his last months, because I think his last months were not easy. During that time, he was diagnosed with congestive heart failure, a weakening of the pumping function of his heart. I think that was related to the known blockages of his arteries, as well as the heart valve disease he had. In addition to that, he then developed a urinary tract infection and probably another infection, an infection of that artificial heart valve that he had. And during that period of time, he was in the hospital at least once and in and out of the office a few times as people tried to make diagnoses, try to help him compensate for his heart failure, and then treat the infection. That was what I would call first phase. The second phase was the acute phase when he came in here in March, which is I think really what we're here to talk about. And that was an emergent phase where he presented with a heart attack and ultimately was diagnosed with very, very severe prosthetic valve endocarditis or infection of his heart valve.
Right, and he spent 5 hours sitting alone, feeling awful in your emergency department instead of getting the care he needed right away. He should have at least gotten an EKG right away.
You're right. I'm sorry that he waited so long. You're right. He should have been seen sooner given his condition. I'm also sorry that the staff were rude and made excuses about the reasons for his waiting. We strive to have people come in here and receive kindness and help they need. And it's always terrible disappointment when the opposite happens. So I want to truly apologize for that. Also, your father, your husband, should have gotten an EKG earlier when he came into triage based on his complaints. And we've done a number of things looking at the process in the ED to make sure that in the future that happens for every patient who comes in like your dad. I think that even if your dad had gotten his EKG in triage as he should have, because of the other diseases that were going on, and Dr. Barr will explain more, that the outcome here would have been the same. That delay didn't cause his death.
So you're telling me that even if he'd been seen right away, he still would have had a heart attack?
Your father was having a heart attack. The EKG was delayed. It should have been done sooner. He went to the cardiac catheterization laboratory emergently, as you know, after the EKG was done. That is all true. I'm afraid, however, that had we done this 5 hours earlier, the overall outcome for your dad would have been the same. Okay? His heart attack, in retrospect, was caused not by cholesterol buildup, but rather a piece or fragment of the infection breaking off the heart valve and lodging itself in the artery. I was able to open that up with a stent. But that's not your typical heart attack. And what we found, as you know, after we got him his stent, was that his infection was very, very severe, and his heart valve was leaking very, very severely on top of the underlying heart condition he had, his congestive heart failure. So the outcome in my mind, professionally, after all my years of experiences, the outcome would have been the same. The procedures would have moved faster, but unfortunately, I think he would have passed just as he did.
The way you describe how things went does not make me feel good about coming to this hospital. My dad had a terrible last few weeks. It didn't have to be like this.
I understand. We didn't give him the best care. You're right. And I'm truly sorry for that. We have reviewed the care and we've learned from this case. So we've added staff into the emergency department who are more frequently checking in with every single patient in the waiting room and redoing vital signs and checking to see how they feel so that we can more quickly identify people who need to come in and be seen sooner. And we believe that change will make it less likely that someone like your dad would come in here and wait as long as he did without being cared for.
I didn't know he was this sick. I mean, I thought they told me that he could live a long time with congestive heart failure. I mean, like a year or two. I didn't think he'd be gone so soon. Why didn't you figure this out when he came in for his checkups?
I think what you were told was correct. Oftentimes people will tolerate having congestive heart failure for a year or two. They may go along very steadily and then have a very rapid decline. Sometimes they can have a more continuous decline. I think that what Sal was experiencing back in December, January, February, could have been interpreted as solely that. At the same time, he had another process going on. He had a urinary tract infection, which was ultimately diagnosed. That can make someone of his age with his multiple medical problems mimic the heart failure and the the symptoms he was having, that lack of energy, lack of appetite. But in retrospect, he had more than that going on. I think that his urinary tract infection probably caused an infection of his artificial heart valve. And in the end, it was the infection of his artificial heart valve that caused his death.
Okay, I can understand, but
Isn't there any difference between the symptoms of a UTI and the symptoms for a valve infection that you could have noticed? Or the fact that he came in to you more than once didn't indicate that there was anything wrong?
Sometimes there are differences. Sometimes it's a difference in the duration of the symptoms. Sometimes it's a difference in the intensity of the symptoms. But oftentimes, there isn't a lot of difference. The urinary tract infections, especially in men at that age, can be chronic. And endocarditis can be very, very tricky to diagnose. And so, yes, there could have been a difference, but there really wasn't in his case. You know, we were able to diagnose it when we had this, catastrophic situation. I want you to understand, though, that even if we had diagnosed it a month or two earlier, I don't think the outcome here would have been any different. All right. There's really only one way to treat prosthetic valve or artificial valve endocarditis. That's to actually surgically go back in and remove the valve and replace the valve. And Sal's condition wouldn't have allowed that under the best of circumstances between his congestive heart failure and his kidney issues and his other issues. And that's more or less what the heart surgeon told us. So ultimately, I think the outcome would have been the same.
okay, I see.
I don't know. I understand what you're saying, but so many things went wrong here. I just feel like this place is in need of some serious help. It's always been my hospital, but I'm not proud of it right now, and I would not tell other people to come here.
Ms. Silva, you are right. We have made many mistakes. But we are here today to be honest and transparent with you and to try to do better. We do take these things very seriously, and I can see that you do too. I wonder if you may be interested in joining our Patient Family Advisory Committee. This is a committee that helps to improve care at the hospital by making sure that the patient and family voice is heard when there is new initiatives or new policies that are created.
That would be good. You would be good at that.
You would be outstanding at that, Melanie.
You speak so well.
But I'll think about it. I'm glad you're going to have one of those committees because it is sorely needed.
Well, I hope that you will consider it. So, Mrs. McDonald, do you have any further questions for the doctors today?
Oh, no, not right now. Maybe later, but this was a lot for me today.
That's understandable. But if you have those questions, and I expect you will, please write them down. You have my cell phone. Melanie has my cell phone. Call me and I'll try to give you the answers you're looking for.
Well, we want to thank you both for coming in, and I hope this meeting has been helpful to you. And again, we are so sorry for your loss. We will continue to keep you and your family in our thoughts and reflections. And we want to make a promise to you that we will do better. We will do better.
All right, well, thank you everyone that participated in that simulation. It was very, very helpful to have those that were in it actually be part of it. So Pat is going to lead this discussion. As I said before, if you would like to participate, please, you can turn your camera on and you can raise your hand and unmute, or you can use the chat box, whatever is better for you.
Great. Thanks, Melinda. Thank you to the actors and also to the Betsy Lehman Center for the support to put that together. I think that Melinda introduced this by saying that this is one of the kinds of cases that it's challenging. I think that's why we get a lot of questions about it, where there was clearly a breach in the standard of care. and really multiple insults to the patient and family, some exacerbated by the pandemic, but probably all of you can think about cases in your own hospitals where there's multiple insults like this, as well as failure to meet the standard of care, but maybe not a causal relationship to the ultimate outcome. And when you think about, I wanted to have some conversation about what are the key takeaways. And I'll start with one of mine. When I watched this video, I had read the script, but it was watching it for the first time today with all of you. And one of the things that jumped out at me right away is the importance of patient relations. When I think about a case like this, I wondered whether the institution would even have known about it through the normal quality reporting channels, whether this would have been reported in a safety reporting system, whether it would have bubbled up through the regular mortality and morbidity rounds or outcome rounds, and how important it is to engage the patient voice in this whole agenda of understanding the ways that we fail patients and families and opening the door for them to have conversations. So the follow through and the connection of patient relations with this risk management patient safety agenda is so important. That stood out for me. And then I think the other thing Melinda opened with when she talked about the phases of the program about this moving toward healing. I think one of the things that jumped out at me was the fact that this was left as an open door for Mrs. McDonald and Miss Silva, with an invitation to come back with more questions, because this is frequently a process that requires additional conversation, but the ability to sit and take in a lot of complicated information for patients and families is a process. And then often the other thing I think that you didn't hear as much here, but could come up in meetings like this, is how much responsibility and guilt family members hold about whether they could have intervened earlier, should they have been there at his bedside. And so these kinds of conversations give rise to the ability to address some of those concerns. So we wanted to open it up. Maybe I'll start. Those were my initial reflections on what I thought as important takeaways, but I was wondering if anyone else wanted to unmute and offer up any other additional important takeaways. It's a friendly audience. I see Dawn, you want to go ahead, Dawn?
Yeah, kind of a question and a comment. I thought that simulation was really helpful. I'm from the University of Minnesota Physicians and am involved in many conversations like that. And one of the things I noticed was I think it was the cardiologist, the provider, talking about his take on, even though these things happened, the outcome would have been the same. So just thinking about, there's times when we have those conversations and the families are very skeptical, being that it's our own provider, right? Saying this, well, of course you're going to say, that because you work here. So in some of those instances where we maybe can predict that will happen, or getting the sense that that might be the response, we've gone outside our own institution to have it reviewed by a specialist. And I was wondering just sort of how that decision is made, with institutions who are doing this, and if that's been something that's been helpful to navigate that sort of skepticism.
Yeah. I know that we have people on the call here who were involved directly with this case, but there is, in my experience, so this is in my experience at the medical center that I was at before I worked at CRICO, and in doing the initial work here, there were times where we would engage outside reviewers, and or we would send the case to our own malpractice insurer and ask them to use outside reviewers. And in those cases, with those particular ones where we felt like we needed outside review because internal review we were either unsatisfied with, or we felt like it would be helpful for the family to be able to say that, we would do that. And you're right, like I think that's kind of one of the things that you can't predict necessarily is going to happen in the meeting. But you should be prepared for. So I'm really glad that you raised that. I think the other thing that you need to be prepared for is what we saw here, which is that that there's a like magical thinking sometimes that we're going to be in the room and we're going to have this conversation with the family and everything's going to be fine at the end. And you just need to be ready for the fact that there'll be affect in the room and it's okay. You know, that you don't have to have a kumbaya at the end of the meeting, right? It's a process and it's okay for there to be a lot of affect. So thank you very much for your question. Who's next, Melinda? Do you, I don't, just Yael or I can't.
Yep, it looked like Yael had to.
Hi, Yael.
Hey, Pat. I love all these comments. I think one of the interesting things for me as a takeaway of, you know, one of the goals of this, besides the communication piece, is like targets for improvement to bring back to the organization. And I think sometimes we focus a lot on, like in this case, there was a delay to care, and we're very focused on like, could that person have gone to cath earlier or whatever. But it was interesting, and you mentioned this, that one of the most upsetting things to the family was actually just, you know, the communication piece, like feeling like they didn't have access or feeling like someone didn't update them. And it's a little harder, I think, just because of the silos and because of our bandwidth of delivering care, for that to be a target of improvement. Like we can say, oh, we're going to measure like time doorway to cath or whatever, but then we don't say we're going to create like a whole separate system of people whose job it is to like update family members who aren't at the bedside. I mean, that feels like almost impossible. But also, it's important to note that that was like one of the major things that upset this family. And the meta piece is often what gets people to like file a complaint rather than the actual delivery of care. So I think it's probably important to acknowledge that and figure out if we have a parallel pathway for like how to address those almost secondary but still critical for the family issues.
Yeah, it's such a good point, Yael. I think there was like a hint of it a little bit from the patient relations in that video, but you're right that we do tend to jump to the things that are like the fixes for the physiology, not necessarily for the communication. So I think leaning into the communication fixes is really important, because you're right, that's what the thing that's most important. Who's next?
Did anyone have any other comments to the two things that were just said? Does anyone? So I think also, I don't know if Doug, you wanted to talk any more about that, but it certainly is part of what we tried to put in the scenario around the communication piece, because I do think, and I know Pat and Lauga, you may also be on the call, but have done a lot of research around the disrespectful piece of adverse events. So it's not only just the actual medical error, but what kind of response are they getting throughout their whole care? Right. And that's something that at this point in time is daunting to think about, but it is something that is sometimes equally as important to patients. So I don't know if anyone else had a comment on that before we moved on to the next.
I think the 9-hour comment wasn't really helpful, right? You were lucky another patient waited 9 hours.
Right.
So I think it's arming staff with the tools to apologize and not make snarky comments.
We did have another question about how do you decide where people sit at the table, and sort of, do you put all of them, patients on one side, providers on the other side? Do you ever mix them? How do you think about that? So, and Pat, you can answer, or anyone that does this regularly, please feel free to jump in too.
I saw that comment right away when it came in, and it is true. So I was wondering what, Edison's going to answer how much it was just a component of you needed to get everybody in the frame versus what you actually do. So Edison, you can answer that maybe. Is that why you're raising your hand?
Sure. Good morning, all. I think when we go into these family meetings, I usually, this is for the purpose of recording, that is how we set up. But I think that for me, when I go into these meetings, I usually like to sit with the family, to be able to show that, I'm there to support them and to help raise their voice with the team. The other piece that I just wanted to speak on was, I think from family members really appreciate the conversation about the technical piece, but it is the communication and the rudeness and the unprofessional of staff that really drives their issues and their concern, because I really think that every organization should have zero tolerance for people to be unprofessional and rude. And I think in doing this work, as we talk about empathy and displaying kindness, is really important in healthcare, more so today through this pandemic, from my perspective.
Thank you, Edison. I think that the offer right at the beginning for when the call came in for facilitating a visitor pass was very helpful as a like immediate kind of service recovery for the call while you were investigating what happened. So really well done. Oh, Karen, you have your hand up and then we can move on. Go ahead.
Good
Karen.
morning, everybody. So my name's Karen Fiumara. I do this work at Brigham and Women's Hospital, and I just wanted to add on to what Edison shared. And first, thank everybody for the amazing acting, by the way, on the video. Could never pull that off. Unbelievably strong work. The seating, in my experience, the seating planning for these meetings is critically important. And while that might sound crazy, but making sure as much attention as I would give to the seating plan for when I'm hosting a big event at home, I spend much more time thinking about it for these sessions. Making sure that our patient family relations team member is exactly as Edison said, sitting with the family and there as much supportive as possible. I usually put myself on the other side of the family and the provider that has the best relationship with the family there as well and as close to the family as possible. And then I have everybody who's going to be doing the majority of the talking in clear line of sight with the family as you can. Because again, I think that eye contact, that leaning in, all those nonverbal gestures of empathy are in some cases just as, if not more important than the actual words that are being exchanged. The other point to mention is that for the past 2 years at Brigham and Women's Hospital, we've tried having in-person meetings with masks versus Zoom meetings unmasked. And I have been shocked at how a Zoom meeting unmasked often feels more supportive than an in-person masked meeting. You just can't see the expression. You can't read it's easier for me to read the room with all the boxes on the computer screen than when everyone's masked, and especially if everyone's getting emotional and the masks, it just makes it a real challenge. So something else for those of you who are working on this to consider, and would love feedback on that if anyone else has experienced similar.
Yeah. Thanks so much, Karen, because you have a lot of experience in doing this. And I think that attention to the room, like what Edison said too, is really important. And, just all those details, I think, make a big difference. I love the observation about the Zoom versus in person. And I'm looking at the chat to see, oh yeah, you're getting us. I don't know if you can see the chat. You're getting some agreements there.
Pat, I like to respond to one of the things in the chat. Hi, everybody. Doug Salvador from Baystate Health. The question I'm looking at is, how do you address the skepticism a family may have? So we're absolutely willing to get an external third-party review of the case and share it with the family. That's not an issue. And I've certainly been in meetings where the family said, you're just, telling me this so I don't sue you. And my response is, this is a process that's separate from the legal process. You have every right to enter the legal process, and there's nothing about our conversation that is intended to stop you from doing that. We just feel like we owe you open and honest communication about what we believe happened. And so I think, to me, going in trying to address the skepticism is sort of the wrong approach. It's really, I'm going to go in. When we teach this, I'm going to leave everything outside the door except empathy. And I'm just going to, as you saw, in as non-defensive a way as possible, tell what I believe is the truth. And, they can believe it or not. But I don't know that, I think trying to address the skepticism can only make you seem more, like you're covering up or fake.
Yeah. Thanks, Doug. One of the other questions that we thought we would talk about here is if you could reflect on that some of the challenges that you might face if you were trying to have this conversation in your organization. This isn't exactly along those lines, but I see that Marcy posed an interesting question in the chat about with a family like this, where could potentially be ongoing struggle. What are the other supports that we have in place to help families grieve? And I was just wondering if anyone has any examples of practices that they put in place for someone or a family like this, aside from just meeting with them again and again to provide ongoing support. Anyone? We'll look to see if anybody pops anything in the chat. Anyone? Go ahead, Marcy.
We actually gained the trust of our palliative care chief to offer to meet with the wife of a patient who died, to kind of do an assessment to figure out where she was in the grieving process and what supports might be helpful to her. We weren't able to transition the wife to her though, and I didn't find we had a good mechanism to do that or a way to do that without being insulting or overbearing.
Yeah. It is definitely a challenge. I see that other people use social work for this, other probably things that might be baked in terms of grief counseling. Anyone else have any suggestions? Anyone have any additional challenges that they could imagine of doing this in their own organization if you had a case like this that came in through patient relations?
I just wanted to add to what we were just talking about, though, that the Betsy Lehman Center through Linda Kenny and her team are working on a more robust support for patients and families where they can call and sort of provide what MITS had provided, but in a more robust way. And so that's something that I think is rolling out either very soon or is already rolled out. And so if you want the information and contact information for how you can link patients up with that, we will certainly send that out afterwards as well. So
great. Thanks, Melinda. And I see in the chat, Michael McCoy said a part of the resolution, both with and without financial compensation is a covered therapy program for a period of time. So there are some programs like that. Thanks, Melinda. Challenges, questions? Maybe we'll ask if
let's see. So this
on the team wants to add anything.
Really good one. It says, where the patient's given any support to prepare for the conversation, or how do you sort of prepare a patient coming into this process? Because it probably is something that either they haven't heard about or is very new to them. And, what kinds of things do you tell them about the process and how do you support them through it? I think that's a great.
It is a really good question. Edison, do you want to take that and then I can add, or what the experience is of preparing a patient for a meeting like this? Or maybe I can start. Oh, go ahead, Edson. I don't want to put you on the spot, but if you.
No, I think that, you never know when you go into these meetings where the conversation is going to go. And I think when we get to the point of maybe offering, you said compensation, then that conversation really then goes to our claims department, and it's patient relations makes that referral, and then they continue with that conversation.
Thank you. Thank you. My experience with patient relations, I don't know if there's anyone here on the call that could speak up from patient relations, it would be that we would have the patient relations would wind up being the first point of contact and the ongoing point of contact for the family, and would set the stage for what to expect in the meeting, who was going to be there, how long potentially the meeting would go, try to elicit the questions so that we would be most efficient in getting and effective for the family in answering those questions, just so that the patient would be prepared when they walked in the room about what to expect. I don't know if anybody wants to add anything from a patient relations standpoint or a care standpoint. I miss.
I would just add that some sites use this and some don't, but we do in Macrame have some resources for patients that are just like a one brief handout about what the process is like and who they can contact and what to expect. And so some sites do find those kinds of handouts helpful when they know that they're going to be doing a resolution conversation, because it is totally new to those patients. And that way they have something written in front of them. So if that's something that you are interested in or want to sort of craft from that for your own organization, we can certainly send you that, and it's online as well.
Mm-hmm. Mm-hmm.
And this is Edison again, Pat. I noticed that someone put in the chat about what happens if a family member brings an attorney. And I think this is where, our role in patient relations is also very crucial in terms of facilitating that meeting. We have allowed for family members to bring an attorney, but it doesn't turn into an interrogation. And if we find that we're going in that direction, then very skillfully we are able to end the meeting in a way that is diplomatic, and just to say we think that we've come to a place where we need to end this conversation.
Yeah.
And that is usually why we ask the family members who is attending the meetings with them, so that we can also prepare the team for the conversation.
Thank you. Karen, it looks like you want to add to that.
Yeah, if I could just build a bit more. So we've definitely had cases where patients have wanted to bring in attorneys, and we've worked closely with our malpractice insurer to also have an attorney in the meeting with for the organization and the providers. And I've actually found that, I think I see some of our members from CRICO on the line. I'd love to get your feedback, but from my perspective, it's gone unbelievably well. Oftentimes the attorneys will talk beforehand, will share that this is not a deposition. We're here to be supportive of the patients. If the attorney happens to be an attorney who's on the MACRME list and is MACRME, I don't want to use the term approved, but reviewed, that's unbelievably helpful as well, because everybody's there with the same goals in mind. And I think that it actually, in some cases, has felt unbelievably supportive to the family to be able to be, it shouldn't change what we're saying. It doesn't change what we're saying. Everything that we have to share, we're sharing because it's what's right and kind. I love that word, kind, and what we would all want for our loved ones, God forbid, if something like this happened. And I think it does not need to be at all counterintuitive to the process. I think in many cases, it's been additive. And really has worked unbelievably well. And the emotion that's brought into the room is the emotion that's brought into the room, and it's important to prepare for that and plan for that.
Yeah, I totally agree with you, Karen. I think in my experience, there's been meetings with attorneys for both sides in the room, but it's couched as a clinical meeting, not that attorneys talk before, talk afterwards, but it's not an interrogation, not a deposition, because it's a clinical meeting in support of the family. And then I think the little that we know from the literature, which is not a lot, is that patients and families find it supportive to have an attorney when they want one. Fred?
I really don't like to speak in groups like this, but I'm the person that made the comment about the seating.
Yes.
And really, it's not about seating, but I want to say this first before she leaves. I like the Brigham. I had a horrible, horrible experience there, Karen, but she's really impressive. And the nurses there are really terrific. And I've had some good doctors there, but I had an awful outcome after a surgery. But that's not what I want to talk about. What I want to talk about is everybody's got a role here and they have titles and all, but a really important thing for the medical people that provide the services is you're a human being and you're dealing with human beings. They're not just the family or the patient and I'm Dr. So-and-so. I have a line I use. I say, I'm a doctor too, but not a medical doctor. And I have no need for you to call me doctor. I know there's a lot of time and expense that goes on to becoming a doctor, but you're a human first. And if they make that connection as human beings, this will be easy to do. It'll be easy to explain to the family. It'll be easy to explain them with their grief and their anger and whatever. And that's important. Sometimes you hear 1,000 sorries. And I keep saying, that's okay, you don't be sorry, but try not to let this happen again to another person. But I can go on and on, but I don't want to. Karen, thanks a lot for renewing my faith in the Brigham. And you guys are doing a great job. This is great.
Thank you. Thanks, Fred. That's nice to get a nice positive feedback like that. But I think you're absolutely right. It's a great comment about connecting at a human level, and everybody brings something else to the meeting. You know, everybody's got something going on around them. And I think we just all have to be mindful of that, because you're right. It's a really human process, really human experiences experienced by the persons that are all like kind of playing a different role. And the ability to connect like that is probably the most important thing. So this is why we're having these kinds of conversations in big groups, so that we can learn from each other and learn from each other's experience, so that we can move this agenda forward without having it seem like it's so overwhelming and frightening. So thank you, thank you, thank you. Melinda, we have time for Claudia?
Yep, we have time for one more, yep.
Okay, Claudia, go ahead.
Oh. Hi everyone, sorry my camera doesn't, I have too much sun, like it's a bad thing. So it won't, all you will see is like my shadow. But anyways, I wanted to kind of come back and make comment regarding the human, as I think it was Fred, the one that was saying, is there were things that I have found when I have these conversations with the family. I'm one of the risk managers at LA County Department of Health Services. So it's what mattered in the times that we've had really bad outcomes. And then the family and the patient were very surprised when, you know, we met with them. And, you know, the first thing we said is like, you know, we're not here to deny that something happened. We're here to openly talk about, and because the patient, it was labor and delivery, she really didn't know what happened to her. She was, you know, she went under, and so she had all of these different things. And then she kept on saying, my lawyer. And it's like, it's okay if you want to bring an attorney, you know, we just need to make arrangements so that you have enough time, but it doesn't have to be in the first meeting. If you want to have a second or third meeting and you want to bring somebody. And I could just see their faces just completely drop, like, what do you mean? And so establishing that relationship, you know, I was with them the entire time. And what I experienced was, though, that because I was with them for part of the event, I brought the event back to her every time that I tried to communicate with her. So that was the hard thing for me, because I was trying to provide help and do all of this for the family and for them. But for the patient herself, you know, that I ended up talking to the sister more than her, because she said, I'm so sorry, you know, you're nice and the conversations are going well, but every time that she sees you, she goes back to that same experience, so that PTSD. And that was, like I said, it was hard for me to kind of have that effect on somebody. I was like, oh, so just to be prepared for that. You do get the connection, and you know, it can be taxing at times, but just calling in and to say how are they doing, to assist in the aftermath. I do think that having a place for grieving in a formal referral, or like a formal team that can assist them with the grieving process, is a huge component.
Yes.
That I'm trying to see, like, how can we incorporate it here, at least for us. You know, we work with our social work, but you know, it's a very different kind of connection. That's the one thing that I have seen that maybe we need to think about incorporating that support. Yeah.
Thank you so much, Claudia. It's a really good point. And I think it harkens back to some of the earlier points about, like, what is the ongoing relationship with the family, or the surviving family, because you see, if you're reading the chat, you can see some beautiful comments there of the family as experts, but also the institution's responsibility over the long haul with a family member when something has gone wrong. So thank you very, very much. I was wondering why you were having sun. We're having rain here. So I'm glad you said where you are, because we're in a cloudy, dark New England where there's no sun today. So thank you. So I think we're near the end of the questions on this one, Melinda. The one thing I did want to point out is that on the Macrame website, there is a tool for clinicians. There's a communication algorithm that people can refer to. I don't know if we're going to put the link
Yeah,
on that.
Liz can put that up.
That would be awesome to just like kind of wrap this up. This is, I found to be extremely helpful with suggested language, especially when you're planning for meetings, just to think about what are the different phases of a care process, and then what are the ways that you can communicate, some suggested ways. So thank you, Melinda, for putting that in.
Well, thank you all so much. If you have had any questions in the chat, we're going to save and preserve this, and we will answer your questions if you have direct questions. And these are great discussion items for us to bring up in future forums too. So thank you everyone who participated in that. We are going to go on a break now. We will resume at 11 o'clock sharp. So if you come back at 11, we'll resume with our second simulation, and we'll talk some more about how to prepare providers for this kind of program. Thanks, everyone.
Thank you.
See you in 10 minutes. All right, everyone, welcome back. Hope you got enough time on your break, and we're going to resume the forum now. Our next piece, next slide, Liz. Our next piece is a simulation. This simulation is of this is a scenario that is invented, but is one that you may encounter many times, trying to talk to a provider who is involved in a care case about what care is. So something has occurred and it's early on in the process, and you want to try to help that provider to understand why we use care and that the benefits of it, and sort of inform them about it. And so this is a conversation that some of our implementing sites wanted more information about, because they said, you know, what if you have a provider that's resistant or doesn't really know or is really worried about using it? That we've encountered that a few times. And so we, this actual scenario did happen, but it is something that really you can adapt to a lot of different scenarios. So the case that we're going to look at today is a case that did really happen. Of course, the names again are changed. It's a 65-year-old female patient with rheumatoid arthritis. She's seen in an outpatient clinic. She's prescribed methotrexate to relieve her symptoms. After several days of taking the medication, she calls the doctor's office complaining of mouth sores and difficulty breathing. She's traveling abroad, so when she doesn't reach anyone, she leaves a message. Her son calls patient relations the next day to ask them to look into the medication as the cause of the symptoms, and patient relations calls the doctor's office to relay the message from the son. A report is put into the patient safety reporting system, where it is referred for quality review. And then you'll see a sample of the discussion. Next slide.
Hi, Will. It's Chris Robinson. I took a look at that file on Mrs. Lawson that you sent me yesterday with the possible methotrexate prescribing error. Yeah, there was definitely an error. The prescription was written for daily instead of weekly, so the sores in her mouth and her difficulty breathing and confusion are in all likelihood directly related to the methotrexate toxicity.
Oh no.
I wanted you to know so that you can make sure she's alerted right away to stop taking this medication, and that her doctor will contact her with the next steps. I already told Dr. Cosby about this because she'll need to work with the patient to get her the antidote and appropriate monitoring, so she already knows.
Okay, I will definitely follow up on this to make sure the patient knows to stop taking the methotrexate. Thank you for your quick review on this file, Dr. Robinson. I will call Dr. Cosby now to make sure she understands what she needs to do. I appreciate it. Hi, Dr. Cosby. This is Will from Healthcare Quality. I wondered if you had a few minutes now or later to talk?
Sure. I'm free for a few minutes now.
Okay, great. I'm calling about Mrs. Lawson. I know Dr. Robertson has already spoken to you about calling her to make sure she stops taking her methotrexate immediately.
Yes, I've already done that. And we've talked about using the leucovorin and the rest of her treatment. And I've set up some monitoring for her. I can't believe I wrote the wrong frequency on that prescription. I feel terrible. I just don't know how it happened. I can't figure it out, and I really feel awful.
I know. Of course, you never meant for this to happen. You are a good doctor, and you care deeply about your patients. Everyone makes mistakes. It is my job to help you through this, and also to help improve the systems around you to prevent this kind of thing from happening again. The best thing we can do now for Mrs. Lawson is to support her and do right by her. The way we do this at the hospital and all of our ambulatory care sites is through communication, apology, and resolution, or the acronym CARE. Have you heard of this?
A little bit. I don't really know that much. I remember something about it at a presentation, but I don't really.
Communication, apology, and resolution is how we resolve any kind of adverse medical event that happens at the hospital. We investigate what happens, why it happened, and then we meet with the patient to talk about our findings. We are honest with the patient and allow them to ask questions and talk with us. And then if it's determined that we did not meet the standard of care and that caused her harm, which is likely in this case, then we compensate the patient proactively through our insurer. We have used this process hundreds of times, and it has been very successful.
Is this going to go on my record? I mean, will I be reported to the NPDB? I mean, everyone will know, right? Is this going to prevent me from ever getting a job again?
You will not necessarily need to be reported to the data bank, and this certainly won't prevent you from getting a job again. As I said, doctors are people and people make mistakes, and those who do credentialing are very aware of that. A single data bank report does not indicate anything about the quality of physician you are. When we do the investigations of what happened here, our job is to try to identify the true root cause of the error, which are often systemic, that you were able to write the prescription in error, but that it was not picked up by anyone or any system is a puzzle we will need to solve. There are likely systemic issues here, but even if it was a true human error in the end, the care process helps us in reporting as well. The databank does require reporting of all payments on behalf of a provider like yourself if a demand has been written. But it now has a special category of reporting a payment when it's done through a care program to demonstrate the provider's willingness to be transparent and to do the right thing. We believe in empathy and transparency, not only because it is what we would want as patients, but also because it's better for providers and it builds trust with the patients and families.
Okay, I mean, the patient already knows about it and she has suffered. I certainly don't want this to become a lawsuit.
Of course, no one does. And that's why we use CARE. It is putting our best and most empathetic foot forward to resolve this in a way that creates healing.
Okay, what do I need to do?
For now, just focus on making sure that Mrs. Lawson's treatment is working and that she's feeling better. Next time you're going to talk with her, we can review what we know so far and what to say. But generally, when you talk to her, you can apologize for what happened if you have not already. You don't need to take full responsibility for what happened, as we don't know the details of how and why this occurred. But certainly you should say that you are sorry this happened to her, and that we will get back to her with more information on how it happened. Feel free to answer any questions she may have about her clinical care. She's already in touch with patient relations, so she can direct any follow-up questions she has there if she wants to know more about this care process.
Okay.
Do you have any other questions? Are you feeling okay yourself?
This is just awful. I feel terrible. I just wish I could rewind time and not have done that.
I know. I'm so sorry. Like I said, Dr. Cosby, everyone makes mistakes. Doctors, nurses, even myself. We do have a peer support network if you feel like it would be helpful to talk to one of your peers who understands what it's like to be in your shoes every day. It's purely for support. Nothing is documented, and the folks that are peer supporters are really caring colleagues already working with you. And many of them have been in the very same kind of situation you are in right now. I will send along their contact information. Please reach out to them.
Okay, thank you, Will.
You're welcome. Please don't hesitate to reach out if you have any more questions or concerns, and I will keep you posted on things from my end.
Okay, thanks.
Awesome. Goodbye.
Bye-bye.
Okay, great. So we will have, just like our last discussion session, same format. You can feel free to raise your hand and unmute and talk if you'd like, or we can use the chat. Oh, Pat's screen is not working. Well, that's okay. I'll start. And then when she gets that fixed, we'll go. So As part of the care program, we do try to do a lot of education for providers ahead of time. This is something that is constantly needs to be on the radar. Go ahead, Pat, if you want to continue. I was just saying how we usually sort of set the scene. So when we're implementing a care program, a lot of it is about education, right? So we go to different departments, we try to tell them, some basic information about this, the data, why it's a good thing to do. And really we're focusing on how to get in touch with patient safety or risk management, right? So like, that's what we want to focus on. But we know that they get so much information all the time that oftentimes they will need some just-in-time information about this. And so that's why this is set up in this way.
Great. Thanks, Melinda. So maybe we can open it to the audience to see what people thought about this conversation. What went well? Any comments on what people appreciated about this?
It looks like one person said, great to see how peer support was offered. That's often a question we get is how do you like put that into the conversation and how do you put it in a way that's easily accessible to them?
Yes. And this just-in-time reminder about peer support is really important too, because it's like you said, Melinda, people hear about all these different programs in organizations, but until they're actually in the moment, they may not fully appreciate it.
Mm-hmm.
Do you think that based on this video that the provider reaction was realistic, given your own experience? Or does anybody have a story of encountering a similar situation that didn't go as well as this one? No? I mean, I can speak personally that sometimes, and I don't know anyone else who wants to jump on, that this is a conversation that takes a little time for some people just to wrap their head around all of the implications of doing this and how are they going to be supported. And then the question about the NPDB is often an early question that people get. And so putting that risk into context, I think, is really important for providers. Karen?
So the point that I'd love to echo is, in my experience, in both of the videos, the brevity with which these conversations happen is impressive. Because it's very, and it could be that I'm just painfully verbose, but these are often, there's often a lot of emotion. These are often long conversations, and especially when talking with the providers who are, at that sharp end of a medical error and a subsequent harm event resulting from that negative that error, the time and attention that's required during those initial phone calls is significant. And I have some comments later on that I'll share that oftentimes the offer for peer support, it needs to be made many times throughout this process, because oftentimes initially there won't be acceptance, or but then if you follow up a few days later or even a week later, and oftentimes I'll just call to check in after a call that was that I know somebody's struggling with, or I get a sense, I shouldn't say no, that my spidey sense goes up and I'm concerned for them, but it's often on that second or third offer that folks will in fact accept the offer of peer support. And I do think that a best practice is if it can be pushed instead of had to be pulled from the provider. What I often say is, as a matter of course, anyone that's involved in anything like this, we have a member of our peer support team reach out. Somebody will be in contact with you. And then sometimes they'll say, no, I really don't want anyone calling about this. I totally understand. I'm going to circle back with you in a week. You might feel differently, and we're here for you, etc. But these conversations take a while, and I actually think the actor was able to be won over rather quickly.
Yeah.
Especially as it pertains to, what does this mean from a liability standpoint? And those are nuanced conversations, and oftentimes we don't have answers to many of the providers' questions in the moment. But what we do know, something that I often say, and I would love feedback from others on if this is the right or wrong thing to say, any of our patients can file a lawsuit or claim at any time. What we know from what's been published in the literature is that using this process does not make it more likely that a lawsuit or a claim will necessarily be filed. So let's go through the process. We're in it with you. We will support you. And you have my cell phone anytime you need to talk.
Yeah.
Some of that language, but would love others' feedback on that.
Karen, I think I appreciate your comments, and I do think for the purposes of the session, this could be a conversation that we could take the whole morning with particular providers, right? So it is a kind of a compressed situation. So you do have to prepare for a conversation like this, if you can, that it could be multiple conversations. I really appreciate the push of peer support as well, and I'd be curious to see what other people think about that. So it's I appreciate your comments on both videos. I think both of those videos are really truncated about what could be a very, very long agenda.
For sure.
It does look like there's a bunch of things in the chat that are related to the NPDB. And so, Melinda, would you just describe the language on the new reporting form that allows you to say that the settlement was made as part of an early resolution?
Sure. Yeah, this is a relatively recent update. I would say it's been around for about a year, and we have been reaching out to lots of insurance companies and credentialing departments at different facilities just so that they know. But it has a new selection so that you can, when clinicians is being reported to the data bank on the form, it will say used CRP type program, and you can check that. And then you can write a description of how that was resolved. And so what that does is it shows that the provider was willing to do this in a transparent and honest way and work with the patient. And so before you couldn't distinguish, it was just like, this is a claim and this is the monetary value of that claim. And so now there is a way to indicate that so that when credentialing bodies look at that, they can see that the provider was participating in this kind of program, even if it was compensation on behalf of that individual provider. So we can send around some slides. It's sort of, we have screenshots of how it looks and suggestions for that too. So we can send that around after.
This other question about whether or not an NPDB report is required if there's no written demand is one that we've been around and around. And I think this actually is one that varies likely by malpractice carrier or insurance carrier or who reports. So I think there are some institutions that would not report if there was not a written demand.
Yeah, you're right. I think it goes both ways. One of the other questions that we've had also came up before. This is a first conversation with this provider, but there would be some more preparation for this provider around talking to the patient. And we've had a lot of questions sort of how do you prepare providers for some more of those conversations? And so from a risk management, patient safety perspective, like what are some of the things that you could do? So I don't know if anyone wants.
Alan Woodward has his hand up.
I just wanted to emphasize.
To add the NPDB. Go ahead, Alan. Nice to see you.
I just wanted to emphasize on the National Practitioner Data Bank because there have been a couple of questions. And this is something we worked with the National Practitioner Data Bank to accomplish. First of all, a clarification that there has to be a written demand for payment. And then the payment has to be made on behalf of that individual named in that written demand. So if instead the payment is made on behalf of the institution because it's determined as systems error, it does not have to be reported. And if indeed there is a written demand and the payment is made on behalf of the individual, then you can report it as a CRP process rather than as litigation or a settlement. So I think that this should, if it's properly explained as it was in the scenario, I think that should quell much of the angst on the part of physicians who've had a lot of, concerns and even excessive concern about being reported to the bank.
Thank you very much, Alan.
Thanks, Alan.
Other questions or comments?
I just wanted, hi, it's Will Garcia from Baystate.
Hi, Will.
Hey, I just wanted to make a comment that in preparing our providers, most of the time I just reinforce that we want to stick to the facts. We don't want to put any hypotheticals or talk about what we think really happened. We just want to stick to the facts and inform the family that we are looking into this event and we will get back to them. So it's a continuation. It's a conversation that continues. It isn't just one phone call. And when the provider is talking to these patients, always remembering that they're only stating the facts and that, they're supported by a team that's investigating, and then we will get back to them with those findings.
Thank you very much, Will. That's a very good point. And Dawn, I see you have your hand up. I can see you in my corner here.
Just two comments, one on peer support. Similarly, I don't know if my colleague's on, we push rather than pull. So we say something very similar to what Karen said about, we recognize these can be stressful events, and part of our process is to have a trained peer supporter who's been through this reach out to you. Just wanted to let you know. And unless they say, no way, we just go ahead and match up a peer supporter, and then potentially follow up with them. So it's a push. And then the other thing I just wanted to mention around preparing providers, all great comments. We're part of the PACT collaborative, and one of the pieces of that work is having a sort of, I know this might be cringy to some people, but like a role play conversation with the provider, especially if it's someone who's nervous. So that's been something that I'm thinking about working on with our providers to actually let's hash this out so that you feel comfortable with any response.
Yeah, I think role playing in advance of the meeting, but also role play, like you could actually do role playing with your risk management team who's going to be contacting a provider as well. And because I think there probably have been instances of providers who refuse to participate. I don't know if anyone has had an example of that where they've had that conversation that went very far and then they ultimately capitulated or did not, that they'd like to share among the sites.
Yeah, I don't think it's that common. I don't know if there's any sense, but I think there's a lot. It's much more common, I think, to have that initial resistance. I mean, if anyone wants to add that, for sure, that would be great. But I think there are lots of benefits to this program for providers, and I think it's more of the fear of what is going to be reported. Does this covered under peer review? And I think somebody asked a question about peer support under peer review too. I just wanted to mention that is not discoverable. The reason why is because, first of all, it's just nothing is written. It's just a supportive conversation. It's not talking about the details of the case. It's talking about emotional support for that person, and so that's not discoverable. But I think being able to prepare the provider for what it means and why it's good is something that, if done well, it should hopefully minimize that resistance in the end. But yes, I think what Karen was saying too is that it's not just one conversation. It's a lot of time spent. That's all the time we have for this discussion. There is one resource that we were going to put up, and somebody also asked if we can get a copy of the chat box. Yes, we are going to have this transcript, and also if you have asked individual questions but we didn't get to them, I will answer them as best we can, and then we also can take them and put them into whatever our next forum will be and sort of have those as some discussion questions. So yes, we'll be able to definitely get that to you. And this is the resource that we have on the Macrame website that just sort of walks through how this would work from a risk management or patient safety perspective, and some of suggestions for actual dialogue.
Thank you.
Thanks so much, Pat. And thanks everyone for participating in all this conversation. And we have a few more pieces left, and we're looking forward to our next forum to continue the conversation as well. So the next piece of our forum is going to be a family member testimonial by Miss Jane Bugbee. And Jane is going to share the story of her daughter, Lindsay, with us. This is something that Jane was very brave to share this story, and she approached me because she wanted to be able to reach those who really can make a difference in healthcare facilities like us in patient safety and patient relations, to make sure that something like this never happens again. And it's really brave of her to be able to share this today. She's also able to do this in part because the hospital where this occurred was using in the early stages of a communication and resolution program. And so you will hear her talk a little bit about that and the difference that it made. And I hope that it shows that when something awful does go wrong, that this is why we use communication and resolution. So I hope that you take what Jane has to say to heart. And so without further ado, Alyssa, you can play the video.
Lynn's my best friend. She was the most selfless, kind, genuine person. As a little girl, she was always happy, always ready for anything. She was spunky, sassy, had a mind of her own. Her first was born. She texted me, she goes, "Mom, I get it. I get why you worry so much about us. I get why you love us so much. Because I have so much love for my baby. And now I get it. I'm a mom. I love being a mom." So it was that next piece. Lindsay gave birth to Nolan. He was healthy. He was strong. She had a seamless delivery. He was delivered on Sunday afternoon, and we got a chance to go see him. Tuesday night, she started with a fever. She ran a temp. The next day, she still didn't feel right. So she had called the doctor, the practice, and said, said how she was feeling. So they gave her an appointment for an end of the day urgent care visit. He looked for inside too, like for anything that might have been left after her delivery. And then he looked at her, he asked Lindsay, he goes, "May I touch your breasts?" And he looked at me and said, "Imagine that, this is the only job that you can actually ask a woman to touch her breasts and it's okay." So he examined her and everything appeared fine. She had a lot of abdominal pain. He also said too that, this is your third child, sometimes it's harder that way, it's harder. So he's just trying to kind of give reasons why there was pain, So she did leave a urine sample, and it was the end of the day, and we left. And even when we were at the doctor, she goes, "I'm just afraid to die." And on Wednesday, because she just felt so uncomfortable. So then on Friday, she had called one of the other OBGYNs, and she said that, she goes, "I don't like what that sounds like." So she goes, "Go to the ER." There was strep in her culture, but it wasn't known. Somehow the communication didn't get through. And so when Lindsay went to the ER, they decided that she had been, that she was constipated, that she needed to have a bowel movement. So after we went to the hospital, they had said, take walks, try to be active. So we took a little walk just down the road of where they live, and we turned around to go. It was just a short distance, and she just said, "Mom, I can't. I mean, Lindsay was in incredible shape. She was an athlete. She took care of herself. She took care of her body. She walked. She was active with the kids, and she couldn't even make it, 100 yards. Her legs were achy, so I massaged her legs with lotion, and she said, "Mom, thanks for taking care of me. I'll take care of you when you get older," And so then Monday, I was planning to go over, just help with the kids and hang out with Lindsay and Evan, meanwhile too, Nolan had he was starting to drop some weight because that's another thing, her milk had not come in yet. Then on Monday, the 2nd, Evan called. He goes, "Are you on your way, Jane?" I said, "Yeah, I'm just coming down the road. I left home. I'm on my way." He goes, "Okay, because Lindsay's just not feeling well at all." And so then I get there, and meanwhile, campus security is there. Evan's got the phone in his hand. Sigrid and Finley, they're eating a popsicle or a freeze pop because they're just trying to be occupied. And Lindsay's sitting on the couch and she can barely catch her breath. And she's sitting there and she's just really uncomfortable. And so Evan called the ambulance. And Lindsay's scared. She's scared. And so other doctors were called. I was asked to sit out in the hallway. Doctors are in, out, and I said, how could this even happen? You know, I just one of the doctors who was on call from her, he goes, "Sometimes you're not sick until you're really sick," and that didn't make sense to me. But and then they let me come in so I could see her, because then they were going to bring her up to ICU. And they told her and me that they were going to intubate her, so that would help her breathe. And she said to the doctor, she goes, "I'm afraid I'm going to die. I'm going to die. I'm afraid I'm going to die." And he said, No, you're not going to die. You know, you just." And so that was that was July 2nd on a Monday. And then everything is kind of blurry until Wednesday, the 4th. As far as timing, they took her uterus. They took, trying to save her. They took her intestine, and then they took over and over, and they flushed, I think, tried to clean everything out. We were just sleeping in the waiting room. And we're, friends and family. We'd go see her a little bit here and there, talk to her. Evan would play music for her. He'd show her videos of the kids so she'd hear their voices. He stayed with her and would talk with her. We'd go in and we'd pray with her. And Evan brought pictures that the kids made, so that when she woke up, she'd see them. We just had family meetings with Evan and the doctors, and eventually they just said, we can't do anymore. I just remember them, a whole group of them in the hallway talking to us. And I remember I don't even remember who was there, but I know just their faces, and they worked so hard, and they did work hard, and trying to not let this happen. And I just remember a young woman just crying too. She was like an assistant or a PA, or I don't know, but I just remember. And we just all just crumbled. We just all just in the hallway there just crumbled, and outside of ICU, and then we had to say goodbye. And that was like, I couldn't even believe that's what we were doing. About maybe a week after Lindsay passed away, because he spiked a temperature. And they said the pediatrician said, "You need to go to the hospital," and especially in lieu of everything that had happened with Lindsay. And so, and he had strep too, and then he had to be in Children's Hospital for 14 days. Another infectious disease doctor had come in, and we're talking to him across the crib, and we were saying something. I think the fact that Lindsay's breast milk hadn't come in yet or something. He goes, "Well, that's a sign of infection, and you kind of go, well, then how come the people who should know don't know? Or how come the people that should know didn't react, didn't respond, didn't look for what could kill her before they decided that she was constipated? You know, those kind of things, those questions start to bounce around in my head. Like, if you trust the people who should know, and at least, you know, and you feel like, okay, because I beat myself up. I go, how come I didn't push harder? How come I didn't, she was advocating, how come I didn't say, well, we're going to the hospital right now? How come I don't, I feel like I let her down because and I know it's because you believe, you trust to the people who, I know people make mistakes. I know doctors are people, they make mistakes too. I just feel like this was one of those mistakes that shouldn't have happened. They shouldn't have made this mistake. Because she spoke loudly. There was the investigation, and I know they communicated about what actually happened, you know, shortly after, you know, when the autopsy and all the labs came back and all those kind of things. But as far as just even touching base with us as people, you know, as family members of like what was going on kind of behind the scenes, what was going on with Linz, and how what she was telling us, that was not,
what you were witnessing.
right, and what we saw. You're right, that wasn't communicated in that manner. You know, that personal piece wasn't there early on. It wasn't there early on. You know, I think people sometimes are, you know, are afraid to say things. We entered into mediation, and the first day that we sat, it was a 2-day process, I remember, and I remember sitting at this big table in the lawyer's office, a conference table, and sitting across from, you know, the chief of staff or the president of the hospital, and, you know, the head of OBGYN, and the head of nursing, OBGYN nursing, and they were wonderful. I mean, they said, we know this shouldn't have happened. You know, and they were apologetic and sympathetic and empathetic and kind and really wanted to implement protocols and programs, and that so this would never, ever happen again. And I know since then things have improved. The head of the OBGYN department was charged with the task of, you know, making sure things would be put into place so what happened to Linz won't happen again. She has a heart for women's health, and to prevent things like this, and to educate her staff, you know, and she wants that to grow because she doesn't, and her heart is so so good, and so she's been really great at facilitating a relationship with us. In my head, like intellectually, I know that by putting systems in place, that so that what happened to Lindsay won't ever happen again, doesn't make me feel any better. It doesn't give me peace because we've lost Lindsay. My grandchildren don't have their mother. My son-in-law doesn't have his wife and can't share their lives together and grow old together. And they can't raise their kids together. It's so important that they listen to their patient, not be so sometimes like clinical in the sense that, you know, like patients know their bodies, you know, and they know what's not right, and to really try to be in tune with that human piece of just of their patient, and that their patients, you know, like my daughter wasn't just a patient. My daughter wasn't just a person who went and had a baby. You know, she was a mother, she was a wife. In anybody, I mean, any human, I mean, it's, sometimes I think sometimes we're not looked at as people, you know, and humans, and whose life has value, I guess. So I just.
Well, thank you, Jane, so much for sharing that story. It's just heartbreaking, and I know that everyone on this call today is never going to forget this. We will share whatever comments you'd like with Jane, so if there is something you'd like to send to us or on the chat, we will make sure that she sees them. Okay. Very, very powerful. So finally, today in our forum, we're going to have our board member testimonial, and Karen is going to talk a little bit about her journey with CARE and how it's at the Brigham right now and what she feels is really important about this program. She's the Executive Director of Patient Safety and Department of Quality and Safety at the Brigham. And so, Karen, we're going to spotlight your video so that you can talk.
Thank you so much. I have the pleasure of often being able to present, and many times I say, "Ooh, what a tough act to follow," but that was definitely a lot. So I'm here today to provide an overview from the board regarding our experiences with implementing CARE. And I'd like to start by sharing that we at Brigham and Women's Hospital, I think I mentioned before, you know, my title is I'm the Vice President of Patient Safety at Brigham and Women's Hospital. In that role, I have the privilege of overseeing the departments of Patient Family Relations, our Patient Safety Department, as well as our Risk Management Department. And in 2017, we joined Macrame. And what I'd love to spend, you know, my 10 minutes going over is really the key learnings and findings that I'd want to share with all of the members, as well as everybody that will be listening to this presentation moving forward, on what are the 3 key learnings that I really think I've taken away. And one is that it's so important to learn and acknowledge those that have paved the way doing this work before us. The University of Michigan work, the Stanford work, and the Massachusetts hospitals that came before Brigham and Women's Hospital, BI, Baystate, the community hospitals associated with BI and Baystate. I mean specifically Doug and Pat and Melinda, thank you so much for your guidance and mentorship as we've struggled along the way in trying to implement these programs. It's been such a pleasure to have Macrame as a support group to really help move these programs forward. I also think it's critically important as you're working through these programs to constantly and critically stay loyal to your true north. And when I say your true north, to me, it's 3 things. Number 1, putting the patients and the families and what's best for them first. 2, and it's a close second, is how do we support our staff and our employees as we work through these processes, and how do we provide the most supportive environment for both of those groups. And then finally, making sure that you're constantly and always iterating over time and knowing and being kind to yourself as well. So I know that we don't always get this right. And despite best efforts, whenever we're involved in a case, it's after something terrible's happened. So right off the bat, you have, you don't get a batting average, right? It's 300 is not good enough or even close. If you don't hit every single ball that's thrown across the plate out of the park, you strike out. And to that end, it's really critically important to make sure that you're constantly thinking about how could I have done it better and how will I do it better next time, and getting better as you move forward. And I can't remember who it was. I think it was Edison who mentioned kindness, and I had made these slides before this, but I think putting kindness first is without question critical. So I'd like for us to go over some of the goals of these communication resolution programs, and then talk a little bit about over the past 4 or 5, 6 years, what I've learned is often the reality. And of course, the goal is to, after an adverse event or an unexpected, unanticipated outcome, to communicate as soon as possible with patients and families and provide great coaching around disclosure, as well as peer support to the providers involved. And what we've learned is, and Fred, I was so glad that you mentioned, and I reached out to Fred via the chat privately, that unreported events can't be reviewed. And we know that we miss cases. And it breaks my heart when I hear something like what Fred had mentioned earlier. But it's critically important that every time we hear about something, we review it. But the reality is unreported events can't be reviewed. And we know that sometimes cases happen that we don't hear about. The coaching and peer support is critical to offer, and unfortunately, oftentimes refused. And really providing a supportive process around that's critical. Another key goal of these programs is to make sure that you're staying in close contact with our patients. And the reality is there will be patients that you're going to lose to follow-up, despite Herculean efforts to stay in contact with patients. And when that happens, we always send a letter that via certified mail where appropriate that says we're always here if you want to engage with us, and anytime you want to come back and talk to us, we will be here to have conversations with you about the care that was provided. Our goal is to conduct reviews in a timely manner, and at Brigham we leverage what's called an equity informed high reliability approach to case analysis. And the reality is, every single review that I've engaged in, I feel like takes longer than I anticipated. And it's unbelievably painful. You set metrics, you set targets, you follow up, and yet somehow they almost always take longer than anticipated. And ensuring equity really takes intentionality and strict discipline. I think this is an area that I'm not entirely sure we spend enough time thinking about and talking about. I've started to try to look at our care cases based off of real data, race, ethnicity, language, and to try to understand, are there disparities? And even the cases that are brought to us or raised, and how can we ensure equity in all that we do? And I do think this is an area that there's opportunity. And I'd encourage all of us to really try to think about this, not as an add-on, not as something that the DE&I and equity folks are dealing with at our organizations, but really just core to all of our work. We try to take within the Department of Patient Safety and Quality and Safety an equity informed lens upon everything. And I think that's really critical. Our goal, of course, is to openly and empathetically relay the findings of our case analyses to patients and families. And the fact of the matter is, you have to plan for a range of emotions from your patients as well as your providers.
and as well as yourselves, those of our patient family relations staff, those of us that are facilitating these meetings. I went however many years in my career before I started having these meetings, and I could probably count on one hand the number of times that I was emotional as it resulted to clinical care of a patient. I can sincerely share that the 70% of these meetings end in tears and from everybody. And I think you just have to own that. You have to prepare yourself for it. Make sure you have good supports for all of that emotion, as well as making sure that the teams that we oversee are supported, and of course the providers, and of course the patients. And I think this is an area that we really should be focusing on in the future. Yeah, and I know there was some talk about it earlier, but the traumas that families feel, the trauma that our patients feel, I don't think we have good structures in place to make sure that there's a safe landing around all that. You know, as much as we should be referring to our malpractice insurer when appropriate, I often wonder, especially more recently, a recent patient brought this to my attention, and colleague, I should say, should we be referring also to, you know, some type of an emotional support program for our patients that are involved in these events, as well as their families, to help with all of the trauma around all of this. Referring cases to our malpractice insurer is always the goal. And I think you just have to acknowledge that this partnership is critical, and tracking around this partnership is critical. And that there's actually a lot of benefit to mutually exclusive independent reviews. One of the things that we've started tracking at Brigham and Women's Hospital is the number of cases that we feel like, you know, our review found that care was appropriate, but that there was an unexpected event, that then go on, and that's shared and communicated with the families, and then go on to some type of legal action, which of course is always possible in these cases. But then what we try to look at is the percent of those cases that are successfully defended versus settled or lost during a trial process. And that's, I think there's a lot of learning that can come from looking at both of those outcomes. So it's a long game, because you really have to, I've been at Brigham for 20 years, you kind of have to stick with your home team for a long time to be able to track things across the span. But there's a lot of learning that I think on both sides can be learned around that, as well as the cases where maybe, you know, the organization felt like, oh, this is a case where we could have done better, and referred that to the malpractice insurer. And actually the malpracticer said, nope, you know, nothing to see here. But then there's a case that's brought forward and settled. So again, looking at both of those, I think are really, really important to truly dig into. And then finally, you know, we want to provide resolution. And I think it's important to note that resolution doesn't necessarily mean compensation. There's a lot of different types of resolution, and a lot of things can be very meaningful to our patients. So ultimately, how should we be measuring success around all of this? And how do you measure kindness? Do you look at time to resolution? This is a lot of the things that we've seen published in the literature, right? Time to resolution, the number of cases resulting in a high reliability system fix, and then a subsequent decrease in similar events, the number of patients and families compensated, cost of legal fees, the percent of families left happy with the outcome. That's a tough one. What I always say to my team is our outcome metric is not did everyone leave happy, it's did we do everything we possibly could? And did we do it to the best of our ability? Did we address what matters to the patients? And did we specifically ask questions? What can we do? How can we best support you? And this is that piece around, did we support families and patients through their trauma? And then of course, with every single case, what can and should we do better next time? So I think I'm at time, but would love, if possible, Melinda, you let me know if there's a bit of time to share additional thoughts or questions.
Yeah, I think we have time for one question. Karen, I would love if you can describe how Macrame was helpful in your implementation process, and sort of the difference between before and after that, or anything like that that you might want to add.
No, of course. So Before macrame, I think that many of us at BWH would say that we had a really good process where, when harm came to a patient came forward and said, I think I should be compensated for this. So there was a great process to refer those cases over to CRICO and provide our malpractice insurer and provide subsequent compensation. The big difference after macrame was every case, every time, the rigor of the reviews, the communication piece with the families. And for anyone who has not implemented yet, please consider the time, effort, support that is required to do that work, because it's significant. But that ability, and as well as absent a patient saying, we want compensation, making sure that we're having those conversations about what happened, what went wrong, what we're doing differently moving forward, and where appropriate, asking what else can we do? And anytime that, we have the opportunity to refer those cases over to our malpractice insurer so that they can review and assess as well. I really think that's the big difference. Like, this isn't about, oh, we know for sure the patient's going to sue and therefore we have a process to handle that. And also, I don't think we had a really great process and rigor around the disclosure process and the apology process and the communication of the corrective actions that result when you actually have a case like this, and then share the findings and outcomes with the family. So all of that, that big box, Melinda, at the beginning of the presentation, the forum today, you mentioned that section, that big box that's all around that communication, that work. And I am forever blown away by the, I don't know what the word is that I want to use, just understanding of the families that we work with, where they so want to know what we're doing to make sure that nothing like this happens again. And I always ask the question, because I'm just waiting for the day that a family is like, I don't want to hear what you're doing for everyone else. I want to hear why it wasn't in place when my loved one was there. But I always say at the beginning of these meetings, we're going to go over what happened. We'll answer all of your questions. And if it's okay with you, we'd love the opportunity to share what we're doing to make sure that nothing like this happens again. And 100%, people are like, of course I want to know, but I'm just waiting for that family to be like, I couldn't care less.
Thank you so much, Karen. We really appreciate that. And then now we're going to conclude. Thank you, everyone, for being here today. Doug Salvador is the Chief Quality Officer of Baystate Health, and he's also the macrame co-chair. So he's going to wrap up with us today. So go ahead, Doug, if you want to unmute and turn.
Sure. Thank you, Melinda. Thank you, everybody who attended. Thank you to our sponsor, the Coveris Community Healthcare Foundation. And a big thank you to Melinda Van Niel. You did it again, along with the entire Betsy Lehman Center staff, who worked so hard to create a wonderful learning and sharing experience for all of us today. Pat, great job facilitating the conversations, and a thank you to the Macrame Steering Committee, who put so much of their volunteer time and effort in all year long, including to put this learning opportunity together and to make things go forward. Perhaps the most important thank you today is to Jane. Jane, thank you for sharing your story. And part of what we need to do in macrame is to gain inspiration and meaning, to go back and do the hard work to change this healthcare system and to make care the way that all patients and families experience it throughout Massachusetts and beyond. It was a really great morning for me. I always come to these forums and realize how far we've come. So, Dr. Calianos started us off really eloquently talking about how this helps the healing process and how it's really focused on making improvements, and gave us, I think, a really hopeful message and grounded us in why we do this. Melinda really gave us, I think, hope for the great statewide and national momentum for this care movement. And when I sit and think about how far we've come and the nuance that we discussed today in fairly nitty-gritty detail in the two simulations about how to engage patients' voice in the agenda, about how to support the family, how to prepare for the meeting, how to support healing, the importance of peer support, and how to get physicians to offer it. And really, as was said in the beginning, we're really discussing how to do it. We're not spending our time, just reminding ourselves why it's important to do. And that's a very different phase that we've reached. My overall reflection on the day really comes back to empathy and humanity in every piece of this. And I see all of us struggling to find a way, not to convince people that this is the most important thing to do anymore, but to do it well, to live up to those ideals of respecting other human beings, of listening to people, of respecting everybody in the process, from the physicians who are hurting to the family members with real loss. And I think we're really moving forward. So I want to leave, the COVID pandemic and the 2-year clinical trial that was referred to earlier, hopefully is lifting. And I want to leave us with a hopeful message of, now's the time to dig in, take the inspiration of this morning, and work harder and harder to get this right wherever we work. So best to all of you. Good luck with your efforts as you continue to experience and learn. Please bring those learnings back to Macrame so we can all benefit from them, and as Macrame has been such a great venue for doing going forward. Take care, everybody. Have a great day.
Thank you all. Thank you.